Hey, good to see you. So let's talk about plantar fasciitis today. And this is part of a new series we're doing called the Running Injury Series, where we'll go over a common running injury, talk about what we'd find on an evaluation or an assessment, and then go on to talk about what a plan of care would look like. So let's talk about a little background about plantar fasciitis first. So plantar fasciitis is one of the most common running injuries. In fact, if you've worked with runners, and I would even say if you've worked in outpatient orthopedics or if you've worked with patients in the past, oftentimes you've come across plantar fasciitis at some point. So plantar fasciitis being so common, it's something we want to be able to know how to address, know what to look for, and really be able to help these patients and runners quite a lot. So plantar fasciitis does have a lot of instances of injury. 42% of middle distance runners, 25% of long distance runners are affected, and certainly a lot of those people are seeking medical services. The problem is that there's a lot of variance in terms of what practitioners will do with patients that have running related plantar fasciitis. Some of them do a running gait analysis, some of them do a more traditional objective exam or PT exam or rehabilitation exam. And so there's a lot of different things that practitioners will do. And certainly if someone is running, it is a good idea to take a look at the way they're running, especially if it's being aggravated by plantar fasciitis or the plantar fasciitis is coming from the way that they're running. So what might you find on a typical evaluation for plantar fasciitis? Now, I tried to pick a patient that was one that was kind of representative of a lot of people that would have plantar fasciitis. Obviously, each patient is different, and so this patient does have some specific things to them that may not be typical in plantar fasciitis. But I did try to pick a pretty representative patient, and so if you like, you're welcome to access the running videos. There's 2 videos and they both have YouTube links. You can find these on solutionseducation.com under the blog section. You're more than welcome to find them also in the link. I'll put them in the comments. So whatever place you want to find them, please access them because they will be helpful to view. If you're not viewing them, you can listen to the findings we'd see. Certainly that would be helpful as well, but it might just be helpful to view them just to make sure you're on the same page. So let's go over a little history first, and I will give it a little bit brief. This patient is 45 years old, she's female, and she's presenting with right plantar fasciitis or right plantar fascia pain. It started 3 months ago, and she's getting pain, which is a 4 out of 10 when she's running over 3 miles at 9-minute mile pace. Here's what we found on a posture analysis. She has pes planus bilaterally, moderate arch height in non-weight bearing with minimal arch height in weight bearing, and genivalgum bilaterally. Additionally, on a running gait analysis, we found she had an increased foot progression angle on the right-hand side versus the left. She had overpronation bilaterally, subtalar joint valgus collapse bilaterally, heel strike bilaterally, genivalgum bilaterally, hip drop bilaterally. She had a narrow base of support, meaning that the feet crossed over each other over midline, and a cadence of 170 steps per minute. Her running shoes that she wore had a minimal arch support, minimal rigidity in the outer sole, a minimal heel cup support, high cushion, and moderate heel drop. On a more traditional objective findings or assessment, we found the gluteus medius, the right-hand side, a 4 out of 5 manual muscle test strength. The left, 5- out of 5. Quadriceps, right was 4+. Tibialis posterior, right, 4-. And I'm giving you the relevant findings here. Gastrocnemius on the right was a 5-. Soleus on the right was a 4. Single leg heel raises, she got to 21 on the right, 24 on the left in a row. Single leg squats, right was 10 times with valgus collapse, left was 15 times without valgus collapse. And her range of motion, and including the active and passive range of motion, were both within normal limits. So what would we want to address with this patient? What would we want to do for this patient to make sure that they could recover from some of their plantar fasciitis? Well, certainly that starts with being able to orient the most urgent things to address. You could probably address everything we just talked about, but would you have time to do it? Would the patient be consistent with doing 2 hours of things on their own? Or is it maybe good to start with a couple things and then add on more? So I'll give you the most urgent things, However, obviously, there's a lot of different treatment styles. There's a lot of different approaches. Talk to 10 different people. They'll have 10 different opinions. So what I am seeing as what's really good to identify here is going to be excessive overpronation, the subtalar joint valgus collapse, the narrow base of support, the genu-valgum, and the hip drop. Now, with that being said, it's also important to note that there's a couple objective findings that are going to support what we just talked about. So obviously, objective measures and running gait analysis, they don't really work independently. You always want to think, hey, here's what I found on a running gait analysis, and here's what I found on an assessment or an evaluation. Do those things make sense to address those issues? Some of the things we found on that more objective exam, or the more traditional assessment, was moderate arch height with a non-weight bearing being moderate and pes planus during weight bearing. So that arch is collapsing. We can then see that that arch collapsing is telling us, okay, so since the arch is collapsing, that's going to overstretch that plantar fascia. If the overstretching occurs, that inflammation is occurring, those micro tears are occurring, we want to prevent that as much as possible. That makes sense because this patient is doing overpronation, which is also overstretching the plantar fascia. Subtalar joint valgus collapse, that's also overstretching the plantar fascia. So those are definitely things we want to address. When it comes to the manual muscle tests we did, we found weakness in the gluteus medius, quadriceps posterior tibialis, or tibialis posterior. Those are all, again, things we want to address as well, because if we think about it, again, that pressure onto the plantar fascia, the overstretching of the plantar fascia, all of that is going to be occurring because we know they have hip drop, they have genu-valgum, they have overpronation. All that's putting more pressure onto that plantar fascia. So if we can correct that, if we can get them away from that valgus collapse, that's going to help them a lot. So strengthening the gluteus medius, quadriceps, tibialis posterior, all going to be helpful. And again, we're identifying that it's the valgus collapse during single leg squat, it's the hip drop as well. Those things are what we really want to get away from. So that's what we want to correct. Now, we can easily say that we want to correct a couple things, but it's easier said than done. So here's a good idea. When we talk about a plan of care, when we talk about these things we want to address, again, we can give them everything under the sun. What I like to do is give people maybe 3 things to work on. 3 gait retraining techniques, maybe another 3 to 5 corrective exercises, maybe 1 change, like a slight change in footwear, or potentially a slight change in mileage. I don't like to give them too much. However, I want to name most of the things I'd want to give so that you can pick and choose with what might be good when you see a patient that has a similar presentation. So here's some gait retraining techniques that I'd give for this patient with plantar fasciitis. One of the things I'd tell them is to turn their feet slightly inward while running. Or another cue I might say is don't let your feet turn outward. Now, this one is easier said than done. So if you're running with your feet turned out, that oftentimes is due to a lot of different factors. We could have excessive tibial torsion. We could have a retroversion at the hips. We could obviously have tight hip external rotators. So there's a lot here that could be adding to that. But if we're trying to get them more turned in at the feet, or the forefoot more turned in, that can be a really good cue for at least they're thinking about, at least they're trying to assist their body to do that. The other thing that I really like to tell patients is push off with your big toe at the end of each stride. This really encourages them from rolling onto the inside of their arches. This helps them keep the arch and push off with the big toe. So basically what that's doing is helping them not turn their feet out as much, because if you turn your feet out too much, you can't really push off with the big toe as much. And then lastly, keep your knees apart while running, or don't let your knees touch while running. It can be another really good one. We're preventing that valgus collapse. We're trying to keep the knees apart. We're trying to maintain the arches and not put excessive pressure over onto the medial aspect. So getting rid of that medially driven pressure towards the midline. Corrective exercises. Tons of corrective exercises we could give for this patient. Some of the classics, ankle inversion with therabands. That can be done with biasing the tibialis posterior. This is a great one to do. I would say 3 sets of 10 or 3 sets until fatigue. For runners, oftentimes we want to really get them to the point where they're fatigued. Lateral sidestepping with squat walks with TheraBand. So we're going to have this patient squat, sidestepping. Many people know this. We put the TheraBand either around their knees or around their ankles, depending on what challenge they need. I am saying 3 sets of 10. That's kind of arbitrary because we'd want to set a certain amount of space for them to do it. Basically, again, we want them to get fatigued, hit and get those hip abductors, make sure they're stabilizing, preventing that valgus collapse. Single leg bridges, again, 3 sets of 10 would probably be a good number here. And I would highly recommend that you make sure they're getting their hips all the way up to their sky. We really want to make sure they have the activation of the gluteus maximus, gluteus medius. Arch raises with the tibialis posterior. This is going to be basically putting the foot flat on the ground. They're going to only raise the arch. So basically we are getting that posterior tibialis to activate. This is the muscle that is not working hard enough to keep the arch in a good position. So if we can get that to activate, hopefully it's going to be maintained while they run. And then a squat progression as well. Double leg squats to partial single leg squats to full single leg squats into a chair. Again, we want to get that squat to be really, really good without the knee coming inward, without pes planus, without hip drop. We want it to be really, really perfect form. Okay, as we go on here, let's talk about additional treatment considerations. So we talked about corrective exercises, we talked about gait retraining. Those are 2 of the big things that you'd want to discuss or want to go over. However, there is more that you can do, but I caution you, sometimes giving patients everything to do isn't always a good idea. Maybe starting with less is more. So some additional treatment considerations. One would be footwear, giving them a moderate arch support with moderate heel drop and moderate stability could be a good idea. The reason for this is because we don't want to give them too high of an arch. A really high arch is going to push up against their plantar fascia and most likely make more pain. However, we also don't want to give them something that's highly stable. Because if we give them a really stable shoe or a max assist shoe, as we call it, that shoe is really, really rigid. It's really inflexible. And all of a sudden, now we don't have some flexibility and all of that rigid shoe is now pushing up against that plantar fascia. So again, we want to be careful with how much change we make in their footwear. A moderate arch support, moderate heel drop, and moderate stability. And I didn't explain it. The moderate heel drop is actually because we do want this patient to still hit into a heel strike. We also want to maintain that this patient is keeping a normal form that they are using. Oftentimes if we change them to a midfoot or forefoot strike, it's really hard for them to do it because such a low amount of people actually forefoot and midfoot strike naturally, but also it runs the risk of then having more excessive overpronation as well. So we want to be careful with the footwear we're suggesting here. Same with insoles. You may not need them. So I would be careful with changing the insoles if you didn't need to. However, I would highly suggest that if you are going to change insoles, again, we think about the shoes that you're wearing. We think about the types of shoe and insole that we're combining together. We don't want a high arch support shoe and a high arch insole that's going to kind of counteract or be cumulative to be too much arch support. So again, I would say if you're going to get an insole, maybe using it with a neutral shoe. We want to be careful with what you're exactly getting. I would recommend that we keep a moderate arch insole and a moderately flexible insole as well to make sure it's not too rigid. As we continue on here, if necessary, potentially some manual therapy. Manual therapy could be really helpful. Potentially, they might need some treatment, maybe soft tissue mobilization to the plantar fascia. Potentially, they might need activation, maybe a neuromuscular activation to the tibialis posterior. Again, I say if necessary. If we're stretching the plantar fascia and we're making things more mobile, remember, if we have more mobility at the ankle, most likely we'll need more stability. This patient doesn't have stability to start with, so it may be indicated, it may not. And then we might want to change the training mileage. I didn't put in how much she's training here in this conversation today, but it might be a good idea to bring the patient down on their running if they're running consistently per week, and then once cleared by the running expert, then give them a return to run program. If you're not familiar with what a return to run program is, check out our latest post. We also have some information on a return to run program that we talked about last week. The emerging research is really showing that less is more with running gait analysis. We don't actually see that changing everything is a good idea because people are really used to the way they run. They are used to that running style, that running form. If you change everything, it could create new issues. So again, that's why I say take the things that are most urgent, most important to change, and then you can always add more, but it's hard to take it away after you've already changed it or after the patient maybe has a new issue that's come up. Also, I would highly encourage you to think about changing corrective exercises or implementing corrective exercises and gait retraining techniques before you change something like footwear. Footwear can be a really easy way, and a lot of people will ask, what could I change with my footwear to make me a better runner? But oftentimes, patients don't have bad footwear. They have a shoe that's comfortable for them, and oftentimes those comfortable shoes aren't always a bad idea for those patients. However, it's always important to think about if the patient really does need to change footwear, give them a footwear prescription. But I might say give the patient maybe a week or 2 or 3 to try your initial implementations or the things you're addressing with corrective exercises or gait retraining, and then maybe see how it goes and if you do need to change footwear as well. Obviously, as you could tell by our conversation today, there's a lot when it comes to running gait analysis. There's a lot of things you can change. There's a lot of things you can learn. There's a lot of different directions you can go, and the research is all emerging. So if there's a way we can help you become more confident in your running gait analysis, check out our Essentials of Running Gait Analysis course. It's available online for continuing education, for over 6 continuing education units, or one of our webinars as well. In the meantime, please ask if you have any questions. We love to talk about this stuff. Email us, chat us, whatever means necessary. Ask your question. We'll get back to you. And in the meantime, stay safe and have a great rest of your day.